Welcome to Med Evidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by Encore Research Group and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, and I'm here with our third session of Advanced Lipid Profiles with my dear friend and colleague, Dr. Al Lopez. And Al and I have dug into some of the nerdy stuff in the last section, and now we're going to get into the clinical stuff, talking about how we treat our patients. So Al, this is what you do for a living. This is what you do day to day. So let's walk our audience through your thinking when you have a 50-year-old fellow. He comes into your office and he says, "Doc, I am so scared. My first cousin just dropped dead of a heart attack at age 51, and my birthday is next week. And I know I haven't been the best. 30 pounds overweight. I used to smoke, but now I just smoke cigars when I play golf on the weekend. I don't really exercise like I should. I know my cholesterol is high, but I haven't checked it for a while. What should I do? I don't want to end up in the same place as my first cousin." So walk us through how you would approach somebody like that.
I think we can start with basics with this gentleman. So, easy, low-hanging fruit. He's a smoker, and I don't care if it's a cigar once a month. We know that cigars are prothrombotic and proatherogenic. So we know that they help progress plaque and actually increase clotting. So one cigar once in a while or cigarette every day, obviously the more you smoke, the more risk you have, but it's still a risk factor.
Get him off of it.
So stopping smoking is number one. We know he's overweight, so we can talk about lifestyle changes. And I start with this conversation like, what's your why? I mean, why do you want to live longer, and how do you want to live if you live longer? And I think that's an unspoken conversation that people have all the time. They don't really say, how do I live longer in a better form, right? Nobody says I want to live to 90 and be in bed,
Sure.
with a stroke.
Right.
So I have that conversation on, let's change your lifestyle. So you're eating McDonald's every day. You're eating only fried foods. Let's take
fast
off.
Food.
Yeah.
We're not prejudiced against any particular
fast
restaurant
foods. So maybe we can at this point talk to them about reducing red meat consumption, using plant-based meals a couple times a week, eating the rainbow 6 to 8 servings of fruits and vegetables a day, and then exercise. And they don't have to run a marathon tomorrow. Let's just walk. Let's start with a 6-minute walk every day, and then every week let's augment that by a minute.
Okay.
And then getting eventually to goal, and then adding high-intensity training eventually, and then slowly they'll cut, as they cut carbohydrates, fats down, and exercise, they will lose the weight, which is a goal. And then I give them short and long-term weight goals. And, you tell somebody you got to lose 100 pounds by next week, it's not going to happen. You tell them they got to lose 100 pounds in a year, it's probably not going to happen either. But if you give them a 2 to year window and saying, this is minimally what I want you to lose per month, and this is what I want you to lose in 3 months, 6 months, a year, and then this is, if you can lose more than that, we can dance a jig together.
Okay.
I think when you give them those goals, then you set them up for success.
Okay.
The scary thing is the hidden risks. Those are the easy ones, right? Then we can check his blood pressure. Is he really at goal? You really want him in the 110s and 120s. What is his heart rate? We know people with very high heart rates don't last as long. So maybe you'll consider a medication to drop heart rate down if he really has a high heart rate. And then looking at other screening things at that point. So then now is the hidden risks. So you have a cousin or a family member that died at an early age. So now, once you get the lipid profile and make sure they're not pre-diabetic or insulin resistant.
Just to drill into that, would you just get a standard lipid profile to start, or would you just jump right into the advanced lipid profile?
With this gentleman, if he already says he has a high lipid profile, and high for some people is a lot higher than what I'm comfortable with, and normal for some people is way higher than I'm comfortable with. Okay. So I tend to be very aggressive on lipids.
So you would get an advanced lipid profile?
I would get an advanced lipid on this person because he died at, his family member died at a young age, to include an LP(a) and include a direct LD, if his triglycerides have been high before, or if he had a high sugar in the past above 90 or 88 or 90, then I would get a direct LDL on him. And I would do it in layers. If those are abnormal, then I would look at other advanced lipid profiles. But I would do an NMR profile.
He has enough risk right off the bat that you would not mess around with the standard stuff.
No.
You want to dig in. Okay.
I want to dig in a little bit more. Okay. Now, would I get an oxidized LDL on him right off the bat? Not unless he has symptoms that worry me. If he told me I'm really short of breath when I exert myself, but I'm not short of breath at rest. But it's even, if I run, I'm really, that's one thing. But even going up a flight of stairs, most people shouldn't be that short of breath going up a flight of stairs, right? Unless they have asthma or big smokers.
Yeah, so let's assume that he doesn't have any symptoms other than being scared to death.
Then I would do an advanced lipid profile with direct LDL on him, look at LP(a), look at fasting sugar, and then, check his blood pressure, heart rate, et cetera.
A1C or not necessarily off the bat?
Not necessarily. I would look at it, but I'm, again, fairly aggressive.
That's a test for your glucose control over time for the audience.
There's other tests that look a little more sensitive than an A1C. You can look at an insulin resistance score. You can calculate your own insulin resistance score, or you can do a 1 to 2 hour glucose tolerance test, which is a real pain to do because people have got to be there for 2 to 3 hours. They got to drink this kind of
Well, you have his attention,
syrup,
so he'll do at this point anything you want him to do.
Yeah, usually if he's coming and saying that, he's pretty scared.
So he's scared, but he's completely asymptomatic. You're convinced of that. You get the advanced lipid profile. Any other ways of looking at him? Do you get a CAT scan to look at his coronary calcium count? Do you put him on a treadmill? What are your other thoughts about doing other
I
screens?
think if he's if he doesn't have an abnormal EKG, is asymptomatic, doing an exercise stress test to look at functionality is worthwhile.
Okay.
To do a nuclear, I don't think that's the way to go, right? Because you're looking at functionality and seeing what he's doing. Yeah. I don't think he needs an echo unless you hear a new heart murmur. If you hear a heart murmur and it's not been identified before, then yes, we probably want to do an echo at that point, which is an ultrasound of the heart.
Yeah, and again, he's fine. Again, we're just going to keep this, on the internal medicine level that he doesn't have any cardiac symptoms at all, and it's just purely screening.
Yeah, so I think I could do that. Coronary calcium score, I think, has huge value, and it's probably underutilized right now. And that will give us a base layer if he has disease. And so when you do a coronary calcium score, you have a CAT scan of your chest done, and then they read calcium deposition in the arterial wall. So what that reads is that it's hot plaque that's cooled down, and you've left, instead of lava, pumice stone in the arterial walls. And that's what you're measuring, is so to speak, the pumice stone.
Actually, a little trivia, you get what's called an Agatston score of the amount of calcium in the coronary arteries. And we think Agatston is famous for creating that CAC score, but everybody else knows him for the South Beach diet.
Right. He's actually a very interesting gentleman, is still working today, and he's quite amazing to hear speak and to meet.
Neat guy.
He's really neat. The Agatston score, if it's 0, then your chance of having coronary disease is very, very low. It's like 1, 2, 3%.
Correct.
If it's 100 to 200, then you probably have a 5, 8% chance around there.
And most places that you send patients for this type of test will have a nomogram that tells you what you expect at different ages.
Right.
So you can put people into a percentile rank of risk, which can be very helpful.
Again, if it's over 400, then you have very, very high risk of having probably ischemic coronary disease or pretty significant coronary disease. Yeah. But the controversy is, when do you repeat it, and then who do you do it on? So I don't think I would do it on a 30-year-old person. There's no data on 30-year-olds and doing it unless everybody died at 32.
Yeah.
Right? But I think someone that's 50, the gist is it's worthwhile doing it, because that would also might convince him, if it's high, to put him on a statin.
Okay, so you got a 50-year-old, he's
anyway.
Asymptomatic. You're going to get an advanced lipid profile to see what his lipid risk is. But if that turns out to be clean, you're going to just work on his lifestyle.
Heavily work on his lifestyle.
And you would make the argument about a standard stress test, not an imaging stress test, based on just defining parameters for an exercise program.
Well, and I might argue, if it was his brother or his dad at a young age, I might argue that he probably should be on a statin for prevention, right? Looking at primary prevention, preventing from ever having heart disease, And so there is data on that. That's kind of heated at times, but
so
I would convince
let's
him
do
to
a
be
few
on a
what ifs
statin.
here. Okay, so now this guy is a 30-year-old guy, and his 51-year-old first cousin died. Do you change any of your recommendations?
I think you still look at risk factors of hypertension, high sugars,
you don't change
weight.
anything versus a 50-year-old?
We know that you can develop plaque in your 20s. At puberty, you can start developing plaques, maybe sooner than if you have very, very high lipids.
Not that much different. Maybe a CAC score at 50, but not necessarily at 30.
Yeah, not at 30. I don't know if I do the stress test, but I would definitely look at lipid profile, sugars, blood pressure, heart rate, and look at those things.
But if he's 7 years old and he has a family member who dies at 50?
So we know with age that there's a higher risk and higher chance of having coronary disease. But, you know, it sounds unfair, but, you know, if he's I've had 70-year-olds I would exercise 30-year-olds. You know, they're really in incredible shape. So it's partly that. If, you know, I think everybody deserves a chance. And there is data on treatment in 70-year-olds for prevention. So, yeah, I think I would look at a coronary calcium
score. Would you
score.
get that advanced lipid profile in the 70-year-old or not so much?
Yeah, I would. I probably would.
How about a 90-year-old?
90-year-old, probably not.
Okay. So somewhere between 70 and 90.
Yeah.
If you make it past 80, you're probably going to do okay?
Yeah. Oh, probably. And, you know, at that point, there's other things that are going to get you that are going to slow you down, right?
Fair enough.
So.
Okay, now it's a 50-year-old woman, not a 50-year-old man. Do you change anything?
You know, so women present differently. And if you listen to Martha Gulati, who does a wonderful talk on women and heart disease, if you look up women and Google and chest pain, you'll get a woman in a bikini. And she argues that we are not just women in bikinis. We have hearts too. We have something underneath our bras and our breasts. There's a heart in there. And so I think women are undervalued in heart disease, and they present differently than men. Sure. So they may present with dizziness, weakness, shortness of breath, and not necessarily chest pain. Mm-hmm. So I think the workup in women should be just as important.
So you wouldn't change anything between a 50-year-old woman and a 50-year-old man. But hormone analysis, would that be part of it?
You know, there is some data that hormones will help improve. I think it's more symptomatology and how they feel with hormones. Okay. But I don't think I would check it as my first line.
30-year-old woman, would that matter?
30-year-old woman, unlikely unless she has an elevated Lp(a) and she had family members, family members that had at a very early age had aortic valvular disease or cardiovascular disease at an early age. Then I would look at an Lp(a) in that woman.
Yeah, and I guess just for the audience, we don't use statins during pregnancy, so
Not
that
at all.
you'd have to be aware of that in younger women.
Yeah, and pregnancy is a stress test because the whole lipid profile goes crazy. Hormones go crazy. I mean, you're supporting another being, right? So things augment and change in order to feed this embryo, you know, to make it viable. And so, you know, it's a beating.
Okay. So how about the 50-year-old guy now brings in his 15-year-old son and asks you the same questions? Any differences in your approach?
You know, I don't think I do much unless I know that they have a family history of Lp(a). I would look at an Lp(a) in those people because now you look at what we call cascade screening. We're looking at family members that have early cardiovascular disease, and we would look at Lp(a). I would look at, I think cholesterol screening should be done at a young age every 5 years, 3 to 5 years, depending on how bad it is. And
so the 50-year-old guy brought in his 15-year-old son, and he said, I want my son to be screened. You would ask, have you been screened yet?
Right. That was the first thing is, has he been screened and what's your risks? Okay. What other family members have been screened and what risks they have. Mm-hmm. I do a very strong family history from grandparents to parents to aunts and uncles, and then kind of make the assessment on this young adult. But I think if there's a strong family history, I would look at Lp(a) and the lipid profile for sure.
Okay, so now let's change the race of the patient coming in. Does that matter? Does it matter if it was a white person or a black person or Asian or Hispanic?
So we know that certain subpopulations have higher risk for heterozygous familial hyperlipidemia, as you know, so high genetic cholesterol, and also for Lp(a). So we know that it's a higher propensity, especially in Southeast Asians. They need to be treated quite differently.
Does that influence your willingness or threshold for getting an advanced lipid profile?
Yes. So, you know, Southeast Asians, higher risk.
So you would order more advanced lipid profiles in somebody from India, for example?
India, Pakistan, South Pacific. What has not been studied is Filipinos. Filipinos are very high metabolic syndrome, high diabetes rate. I think I would look at those patients as well. Black patients from, you know, African Americans to Africa, you know, high propensity of Lp(a), so I would look at those as well.
So you might be more likely to order an advanced lipid profile in African American versus Caucasian.
Depending on the scenario.
Okay, all right, fair enough.
Yeah, it's nobody's that clear cut, right? Sure. You know, there's very few very clear cut things. If not, everybody would have been diagnosed early, and everybody would live to 100.
Right. Okay. Now, obviously, these are all what we call primary prevention scenarios. Right. So now, how about secondary prevention scenarios where somebody has already been diagnosed with some degree of coronary disease, whether it's, say they had a stent. The same person came in, hey, doc, you know, I need a good internist. I had a stent, when I was 40 years old. I haven't had any symptoms. My cardiologist says I'm perfect, and just go see my internist. And now, just my cousin, my first cousin just dropped dead at 51. Am I doing everything I need to do? So has that changed your approach, particularly with regard to the advanced lipid profile? Let's say that he's been good. He's on 40 of atorvastatin. He's taking his aspirin a day, and he's on a low dose of an ARB, and he said his blood pressure is always perfect.
So it sounds like this person who's had, vascular disease and is on anticoagulant and aspirin, supposedly on the right medication. Sounds like he's in a good regimen. The question is, what is his hidden risk, and does he have any risk factors, right? So this patient, they already have coronary disease. I would not do a coronary calcium score. I don't think that's worthwhile, because that really kind of aligns risk if you should or should not be on a statin, should you do more aggressive treatment. And so the assumption is that they have calcium.
Mm-hmm. But in terms of the advanced lipid profile,
I think in the advanced lipid profile, I think if they have young family members, yes, an Lp(a) with those people. And we know that the recurrence rate in people with coronary disease is almost 70% if you're not on the right medications, or if not higher. And so, they need to have a very low LDL. I've been very aggressively treating patients with low LDLs that have disease and diabetics at 55, like the Europeans have, and American Heart has very wisely lowered those standards as well. So I think this is going to be a big change. So this person, I would look at their lipid profile and make sure they're very low in that. I would do an advanced lipid profile if they have high triglycerides. If they have an LDL of 40 and triglycerides are 70, do they really need, if their Lp(a) was normal, do I need to look farther than that? Probably not, unless they have symptoms.
Okay. So we're going to take a pause here, but I'm going to be really curious in our next segment about how you use advanced lipid profiles over time. Is once enough, or is there information to be had when you look at them over time? And how often do you check? If you get one, you do something, do you check it again in 3 months, 6 months, or a year? So we're going to jump into that discussion in our next segment.
Thanks for joining the MedEvidence Podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.